much, Dr. Sa. Thank you very much, Dr. Hassan, for this brilliant lecture. After this brilliant talk, I'm really honored to welcome Dr. Ahmed Kafafy, who's an amazing guest from UK. Dr. Ahmed Kafafy is the pain medicine consultant and the clinical service lead for pain therapies in Royal Orthopedic Hospital in Birmingham, UK. He's talking to us about a very important subject, which is the pharmacological management of chronic neuropathic pain. And this is like a very important for all of us, even including in neuroanesthesia and in pain medicine as well. Dr. Kafafy.
Thank you very much, Dr. Salam. I'm just hoping that, can everyone hear me clearly?
Yeah, it is very clear. Thank you very much, Dr. Kafafy.
Thank you very much. One of the negative feedbacks I had from last week was that the voice wasn't very nice at the beginning. So my son was very kind and he gave me his PlayStation. And he said, Dad, this will work very well.
Yeah, we were enjoying the lecture anyway, so.
Thank you. Thank you very much for the introduction. Thanks for the great lecture by Professor Hassan al-Manna. It was very interesting. And it's quite difficult to say something after such a very heavy, nice lecture. So today we'll speak about something a bit different from last week. Last week we spoke mostly about mechanisms and pathway of pain. Today it's an important lecture, very important lecture, especially of people who are entering exams, whether these exams are in Egypt, in Saudi Arabia, in the UK specifically, because it's more an evidence-based lecture. So these questions are asked quite intensively, especially if you're attending an exam in the UK. Just before we go and start, I'm just going to apologize because maybe some of the medicines, all the drugs I will mention today are widely used in Europe and also in the USA, in Canada, in different countries. I'm not sure about our own countries because I know that many of the medicines, especially for neuropathic pain, are very limited use in our countries back home, in Egypt and in the Middle East. So also, people who are interested in pain. Pain in the UK is different from many other places because it's very evidence-based. So you can't use any drug for any type of pain. It has to be based on a protocol or a guidance or a policy within your hospital, and you have to justify what you're using. There's something called a pharmacy formally or a drug formally in every hospital, which has got all the drugs mentioned in the pharmacy. You can't bring something that is not, hasn't got an evidence or was not licensed, doesn't have a license to be used for this specific pain. So this is another issue in the UK. So we're going to go through neuropathic pain. So I want you to try and pay attention as much as possible during the lecture. It's 35 minutes, hopefully. The first 20 minutes will be the lecture. And then the last 15 minutes, hopefully we're going to mention 6 case studies, real case presentations. Interesting, and it will be based on what you will hear from the lecture, so we'll discuss them together. Neuropathic pain is one of the most difficult pains to treat. It's a primary lesion or a dysfunction of the nervous system, and that's a definition. So it could be a lesion or a injury to the nerve or a dysfunction to the nerve. So the nerve is not working properly. It's very common, very common. 2 to 3% of the populations in the developed countries suffer neuropathic pain. I've seen more neuropathic pain. I didn't practice much pain in Egypt, but when I go back for and do some cases there in my holidays, I don't find much neuropathic pain than I find in the Western, in the UK. It's very common here. 8% of adults in the UK suffers neuropathic pain, and that's it's one of the most difficult types, as we mentioned, to treat. And it has devastating impact on psychological health and social functioning. First of all, before deciding on any management or treatment, you need to diagnose it. Is it really neuropathic? We shouldn't be giving neuropathic pain to a patient who's got a pure musculoskeletal pain. A patient with pure back pain, which is musculoskeletal in origin, shouldn't receive neuropathic pain. So there are spontaneous features and there is stimulus evoked stimuli type in this pain. It's usually burning. Patients usually come and describe pins and needles, tightness, coldness, feels coldness, feeling hot. Interestingly, some people come and say to you, I'm feeling cold and hot sensation at the same time in my arm or in my leg. And apart from this, you have to have one of the ones on the right side as well. You have to have a stimulus evoked sign, like allodynia, which is increased, which is pain to just touch, hyperalgesia, which is exaggerated pain to a very small stimulus. And usually it's associated with autonomic features like sweating, swelling, motor changes, color changes. There are many types of pain, of neuropathic pain. These are just examples. There are central causes and there are peripheral causes. Stroke. There is some evidence that 15 to 20% of people who suffer cerebral stroke develop pain at some degree after the stroke. Sometimes we see it very early, in a few months, and for other patients we see a few years after. And we don't know the exact mechanism, and unfortunately there is not much treatment around as well. Multiple sclerosis pain, something I don't believe it's common in our countries as well, in the Middle East, I'm not sure, but especially in Egypt it's not common, but I've seen many in the UK, and we have many patients that we treat under our clinic. Spinal cord injury pain, very common as well. Peripheral causes like neuropathy, diabetic neuropathy, shingles or post-herpetic neuralgia, trigeminal neuralgia, any sort of post-operative nerve injury, and the most common is the failed back surgery pain, the radicular neuropathic pain. These will contribute something like 40% of the numbers of patients we see in our clinic. So 4 out of 10 patients that we see and treat are treated from radicular neuropathic pain, failed back surgery, unfortunately. So this slide is very important. So we need to discuss this in some details. Before starting treating the patient, just put in mind that neuropathic pain conditions, many of them are non-treatable. So you need to be very honest with the patient from the beginning. If you see a patient in your clinic that is having pain for 5 or 6 years, severe, he's got peripheral diabetic neuropathy, for example, he might not be cured and he will live the rest of his life with this pain. So you want to manage him, you manage this pain to him to the best that you can do. So you need to be honest with the patient. You need to assess him. You need to find a diagnosis if possible. Sometimes even we fail to find a diagnosis, very frustrating. Comorbidities are very important because the choice of your drug will depend on the comorbidities. You need to treat the cause if you can, and then we'll come to that later, and underline the need for continuous treatment. Tell the patient, you will be under me for the next 2 or 3 years. I'll try my best. Maybe I will not be able to make you pain-free, but I'll try to make the pain manageable as much as possible. And so you need to have realistic expectations. These guidelines I'm going to speak about are based mostly on the quality of evidence available only from RCT, randomized controlled trials, and also based on side effects profile to come second, and then the cost effectiveness, because that's something important in the UK. Although we're in a developed country, you have to justify if you use a more expensive medicine if there is a cheaper one available. Ease of use, if this medicine easy to use. We divide it into first, second, third, fourth line of treatment. First line of treatment is a drug that has got the best evidence. Fourth line drugs are the drugs that has got the worst evidence, worst side effects, maybe the most expensive. And all this has to be individualized according to the patient. As we said, okay, so we start by tricyclic. So tricyclic antidepressants. So sorry, first line of treatment here, we're going to speak about tricyclics and anticonvulsants. These are the most widely used drug and has the best evidence. We're going to discuss that because this is asked a lot in the exam, especially about what do you know about this? Why are you using this drug? Why did you try gabapentin before amitriptyline? Why amitriptyline before morphine? So you have to mention all these things. It's got the best evidence for treating neuropathic pain. Its analgesic property are independent of the antidepressant effect. That's very important because tricyclic antidepressants are designed to be used as antidepressant. So we call them analgesics adjuvants. Analgesic adjuvants. All these medicines we're discussing, most of them today. So they're not mainly analgesic. They're used for other reasons, but they're also licensed and tested to be used for neuropathic pain. And if you remember this slide from last week, we did mention how this drug works. It blocks the reuptake of noradrenaline and serotonin. So it releases more serotonin at the receptor site, and noradrenaline as well. And these are inhibitory neurotransmitters. If you remember from last time, we said we've got good guys and bad guys. So this increases the number of the good guys. So inhibits the pain signals. And it blocks the hyperalgesia also because it's an agonist at the NMDA agonist. It acts as a sodium channel blocker at the same time, as we mentioned last week as well. So it works like local anesthetics. But because you've got more noradrenaline and serotonin, that's why these drugs has got side effects, unfortunately, because more noradrenaline, more sympathetic drive, tachycardia, dry mouth, all of these things. The evidence is very strong. We've got 17 RCTs involving 10 antidepressants, different ones from all tricyclic antidepressants. NNT is 2.5. Sorry, I'm just going to mention some boring expressions, more statistic and epidemiological expressions, but they're very important. So NNT is the number needed to treat. So an NNT of 1 means that the drug treats everyone. If anyone takes the drug, he will be. That's not possible. That's not there of any medicine. And so the lower the NNT, the more effective the drug. So if you have an NNT of 2, means that if you give the medicine to 2 patients, one of them will have very good response to the medicine. Okay. Interestingly, for these tricyclics, they are equally effective in all types of neuropathic pain. So they didn't find that they worked for one type better than another. So DN is diabetic neuropathy, post-herpetic neuralgia, post-traumatic nerve injury and stroke. All of these were very widely tested with randomized controlled trials, and it's proven to be very effective. I'm not going to go in details of doses because we're all aware of that, but please, for any type of neuropathic pain, because unfortunately not everyone practices that, and I've seen that here. It was by the GPs. I've seen in Egypt. So always start low. We always teach our trainees, start low and go up slow. So start on the lowest dose that you can, even if so. Amitriptyline, according to the NICE guidelines, you can go up. Sorry, NICE is a National Institute of Clinical Excellence. It's an institute in the UK that publishes data about policies and guidelines that we should all follow. They advise that the maximum dose in pain of amitriptyline is 75 milligrams, but that doesn't mean that if I have a 70-year-old man with neuropathic pain, I'll start him on 75. I'll always start with 10. And the following week, I give 20, 30, 40. That's how it works. It can cause dry mouth. It can cause constipation. For some people, and I've seen it very commonly, it can cause hair loss. Of course, it's contraindicated if someone has got arrhythmia because it stimulates the sympathetic drive. So arrhythmia, glaucoma, because it increased the intraocular pressure. So I'm sure most of you who've studied some degree of pain will know about all these things. Anticonvulsants are very commonly used, gabapentin and pregabalin. They are calcium channel blockers. And if you remember also from last time, they decrease the bad guys. So the amitriptyline increase the presence of the good guys or the inhibitory neurotransmitters. Gabapentin and pregabalin stop the release of excitatory neurotransmitters like glutamate and substance P. And this is what we know about it. Very theoretical. We don't know much about these medicines in terms of the mechanism of action. 2 RCTs shows that it works very well in painful diabetic neuropathy, post-herpetic neuralgia. The NNT of the gabapentin is 4, which is still good. But the NNH is 50. And you know, the NNH is a number needed to harm. So it's a side effect profile. Do you remember we said the lowest the number for the NHS, the better and the more effective the drug. The NNH is about number needed to harm, is about side effects. The higher the number is, the better is the drug. So this means that 50 patients need to, if you treat 50 patients with gabapentin, one of them will have a side effect. So it's got a good, we call this drug has got a good safety profile. Pregabalin is very similar to gabapentin. We're going to mention the difference now. It's important in the exam about the difference between pregabalin and gabapentin. Studies show that it's effective in 2,000 patients in 8 RCTs. Most of the studies you will find in the pain, they study peripheral diabetic neuropathy patients and also patients with shingles and post-herpetic neuralgia, because this is one of the, I would say, especially diabetic neuropathy, very common type of neuropathic pain that you've got plenty of them, so you can recruit more patients for your studies. NNT for pregabalin is 4.2, very similar to gabapentin. NNH is 11.7. Can you notice that? It's a very low figure compared to gabapentin. What does that mean? More side effects of the pregabalin. Pregabalin is a very sedating medicine. It makes people very drowsy. So not everyone can tolerate it compared to gabapentin. It's approved by the NICE, again, National Institute of Clinical Excellence, in 2011 to be used as a treatment for GAD. GAD is generalized anxiety disorders. Many patients with neuropathic pain suffer anxiety at the same time. If you find the patient have got anxiety, don't give gabapentin, just start with pregabalin. Although it can be more expensive in many places, but it would be more effective. The difference between the two medicines is more a pharmacokinetic difference rather than a pharmacodynamic one. So, sorry, we have to go back a little bit to pharmacology, especially pharmacokinetics, and speak about a little difference. I'll explain it. I'll try to explain it, but it might be a bit tricky to understand in a short time. Gabapentin is absorbed slowly. So if you give a medicine, the peak and the onset of action is slow. Pregabalin is not like this. It works straight away. Zero order kinetic and first order kinetic. Zero order kinetic, so it's a cumulative medicine. So the rate, the zero and the first order kinetic is a clean drug. So the rate of elimination is actually proportional to the amount of medicine in the blood, to the plasma concentration. So more drug, more elimination. Zero order kinetic is the other way around. Actually, the rate of elimination is constant. It's fixed with time. It's not related to the plasma concentration. So these types of drugs that are eliminated by zero order kinetic can cause toxicity. So many of the antipsychotic drugs work with zero order kinetics. So you need to be very careful escalating the dose of these drugs because of the elimination, because it will accumulate and it can cause toxicity. Bioavailability is something very important with any drug. It's 90% for pregabalin. So that means 90% of the when you take the capsule, 90% is absorbed in the blood. So only 10%, as we call hepatic first pass metabolism. It's 60% for gabapentin up to 900. That's very interesting and very important. If you go above 900, the bioavailability drops to 30%. That's why I don't like to put my patients up to 3600 of gabapentin, because it causes more side effects and it becomes less effective. Both renally excreted, both have a similar half-life. Another anticonvulsant, carbamazepine. This is first line of treatment. You remember this very well for idiopathic, for trigeminal neuralgia. Only, not recommended for anything else. I've added this drug because it's a very recent drug, oxcarbazepine. At least in the UK, it was licensed recently also to be used for trigeminal neuralgia, or we use it also for facial pain, even idiopathic facial pain, even if it's not diagnosed with trigeminal neuralgia. Oxcarbazepine is a lot better than carbamazepine. It's got less side effects and it's more effective, but it's expensive. I'm not going to go to the doses. You probably know about these medicines, gabapentin, pregabalin, carbamazepine. You can go back to this slide if you want and look at the doses. That's interesting. In The Guardian in 2017, they came up with this article. Everyone was giving pregabalin and gabapentin widely. Suddenly, it became a class 3 controlled drug. No one wants to give it, and they put a report of 111 deaths linked to giving of pregabalin specifically. So GPs became scared. They stopped prescribing it to patients. They started referring all these patients to the pain clinic with neuropathic pain. Please prescribe the pregabalin and monitor it yourself. That put lots of burden on our service. But if you look at the study that they did, if you look below the curve, it says here that most of the patients that died, 111 patients died from pregabalin, but they were not only on pregabalin, they were also drug addicts on heroin. They were on benzodiazepines like diazepam. So mixing these drugs that all cause respiratory depression can kill. But I haven't seen a single patient, having worked in pain for the last 15 years, that died from pregabalin, solo pregabalin. So you need to be cautious mixing drugs. Second line of treatment is serotonin noradrenaline reuptake inhibitors and the lidocaine and capsaicin. This is the second line. One of these drugs is called duloxetine. I know this drug is available in Egypt and probably available in most countries of the not very popular as it is in the UK. I spoke to some of my senior pain consultants about it, and they said it's a rubbish drug. We don't like to use it. It causes lots of side effects. I find it very effective. I'm going to tell you what type of patients you can use with. It's effective. 3 RCTs involving patients, again, with peripheral diabetic neuropathy. It was widely tested on these types of patients. It causes significant pain relief compared to placebo. The NNT is 4.6, which is good. NNH is less than 15. So yes, the side effect profile is high. But when I spoke to people who give it and they complain there is side effects, again, as I said at the beginning, please, please, please start low and go up slow. The duloxetine, as far as I know, is available in Egypt in only 60 milligram tablets or capsule. This is a very high dose. We start the patients by 20, which is 1/3 the dose, and then we go up if it's effective. Most patients tolerate 20 and 30 very well. The NICE guidelines again came in 2010 and said, please use it first line of treatment in peripheral diabetic neuropathy. Yeah. The bit at the end, I haven't got the evidence yet, but I'm doing a study now with some of our knee surgeons at our hospital of using duloxetine in post-total knee replacement neuropathic pain. It's something that is very, very common in my practice, that many patients have a knee replacement and they come back with neuropathic pain, severe neuropathic pain. Duloxetine, we're trying it and it's very effective. It's helping a lot. But there is some published data, but they're all case reports and some low quality. But hopefully we will be doing an RCT in the next year. Mirtazapine is a noradrenaline and a specific serotonin reuptake inhibitor. So it works only on some subtypes of the serotonin. Mirtazapine is a drug that is mainly used as an antidepressant. It was very widely tested, but unfortunately, doesn't help much for neuropathic pain. So I wouldn't advise this medicine except if the patient plus his neuropathic pain suffers from tension-type headaches. They were tested on 600 patients in Germany where patient had headaches, and it worked very well, especially with the tension-type headaches that affects only the back and sometimes the front of the head. It causes lots of weight gain. So if you have any patient on this and he's overweight, just warn him. Venlafaxine, I didn't speak about this in details because venlafaxine shouldn't be used in pain at all. It's another serotonin noradrenaline reuptake inhibitor. Venlafaxine is one of the best antidepressants. So if you have a patient with severe depression that did not respond to selective serotonin reuptakes or tricyclics, please try venlafaxine. But start on a small dose. It's a very old drug, very ancient drug. The problem with it mainly is hypertension. So keep an eye on the patient's blood pressure and on the mental state and the drowsiness. But it can help a lot with mood. Lidocaine, not going to go in details. We mentioned that last week, that lidocaine patches 5%, very, very effective. You can use these as first line of treatment, not second, if the patient has got only peripheral neuropathic pain, such as what's one of the very common peripheral neuropathic pains? CRPS, chronic regional pain syndrome. Start with topical lidocaine. Versatis, we mentioned that last time. It's a very interesting drug. Versatis is a patch that you apply to the area. It's like 5 to 6 centimeters. It's a square. And you can apply up to 4 and you leave it for 12 hours. It's got 5% lidocaine. You have to have symptoms of hypersensitivity to use it in the UK. So allodynia or hyperalgesia. You leave it for 12 hours and then take it off. Interestingly, it was tested on patients with back pain. It's an interesting study. They brought 100 patients, divided them in 2 groups, 50 and 50, and they gave everyone a Versatis patch. So can you imagine, did it work? How did it work? This is the study in 2012. It worked for everyone. So they put the active drug in one of the groups, and they put a placebo in the other 50. And it gave more than 50% relief in all the 100 patients. Very interesting, because patients, unfortunately, the placebo effect is very, very strong. So the patient came back. If you give a patient a drug and tell him, this medicine is going to help you, it will help to some degree. So very strong placebo. Capsaicin, we mentioned that last time as well. It works on the TRPV1 receptors on the skin. I would go back and read this because the mechanism of action of capsaicin is only theoretical. It depletes substance P, which is one of the very important excitatory neurotransmitters. So it causes heat, very heat, because it lowers the threshold of the calcium channels. Qutenza. Remember this slide from the case studies because we're going to go back to it. Qutenza is a capsaicin, but in a very high concentration. It's 8%. And you apply it again. It's used the same as Versatis, the lidocaine patch, but it's got the active drug capsaicin in it. It proved to be very effective in HIV neuropathy, patients who've got AIDS, HIV, very common in our country here, very common in the UK. Effective treatment also for post-herpetic neuralgia. Third line of treatment, tramadol and controls. Tramadol is a very effective painkiller. So it works very similarly to amitriptyline, tricyclics, inhibits the reuptake of noradrenaline and serotonin. It's also an opioid, but it's a very weak opioid. So it's got some affinity to the mu receptors. Believe me, when I speak with doctors from Egypt about tramadol, it's very difficult to get it. And I think that people use it for different reasons. You know, tramadol is not designed to be used to make people euphoric. It's not used to be used to sexual dysfunction. So it shouldn't be used for any of these, but it's a very strong painkiller and it's a very effective drug. In 3 RCTs for peripheral diabetic neuropathy, it's proved to be effective with an NNT of 3.9, which is really good, NNH of 9. And the reason for that, again, is some people start it very high with the dose. We also start very low with the tramadol. And one of the pieces of advice that we find in our practice is mixing tramadol with paracetamol. So if you ask the patient when they take the tramadol, please take a full dose of Panadol, like paracetamol, 1 gram, with the tramadol. They work synergistically, so they potentiate each other. There is a drug that came up in the UK, it's called Tramacet. Tramacet is a mixture of tramadol, very small dose, 37 milligrams, and tramadol, 325. It's a very expensive drug. We don't use it quite often, but we use the minimum 50 milligram of tramadol to start with, and we ask the patient to take paracetamol with it. I'm going to tell you, if you want the tramadol to work always with patients with neuropathic pain, the best thing is they shouldn't take it regularly every day. They should keep it only for breakthrough pain. They can take even up to 150 or 200 at a dose if they've got severe pain. The problem with tramadol is the quick development of tolerance. So the body gets used to the drug very quickly and it stops working. But if they use it, every patient with neuropathic pain will have good days and bad days. If they only use these medicines in bad days, it will always work. Opioids. Opioids are very, very effective drugs. They work very well, but short term. So if you give an opioid to the patient, in the first few weeks, they will come and tell you, thank you very much, doctor, for the magic pill that you gave me, because my pain is a lot better. And if you can see from these studies, 8 high quality studies, but if you look, why did I put a line under 8 weeks? Because the studies only tested 8 weeks duration. And it's found to be very effective with a very good NNT of 2.5 and NNH of 17. So it's a good drug, but only for short term. Long term, lots of trouble. Hopefully we'll have some lecture to speak about opioids alone, because it's very important. We've got morphine, we've got oxycodone, and we've got fentanyl, and we've got buprenorphine in the UK. Now, after the opioid epidemic that happens in the USA and all the problems, the widely used drug is the buprenorphine, which is called Butrans patch. We have many generics from it in the UK. So we've got Butrans, Relitrans, and other ones. Butrans is the safest opioid because it's partial agonist. And we also use it to withdraw people who are on very high doses of opioids. You can't imagine, we get patients to our clinics who are on 400 mics of fentanyl, 600 mics of fentanyl, and then the GP leave the patient to us to deal with. It's very difficult to take them off these medicines. We use buprenorphine and methadone to do that. Fentanyl patch, I wouldn't advise you to use this at all for any non-cancer pain. So any chronic benign pain, please start by morphine. In exceptional cases, you can use oxycodone only on a short term. Butrans, you can use widely, but apart from this, I wouldn't advise steroids. Tapentadol or Palexia. I don't know if this drug is available in the Middle East yet or not. This is a newish drug. It's been around for the last, I would say, 5-6 years in the UK. Not every place in the United Kingdom can use this drug. It's not licensed to be used yet for neuropathic pain. We personally use it at our hospital. It's a very effective drug. It's one tablet that has got 2 mechanisms of action. It's a very strong opioid, as strong as oxycodone, and it's the same time has got a norepinephrine reuptake inhibitor effect as well. So it can be effective neuropathic pain. Widely tested to be used and proven to be effective. The good thing about this drug, you don't develop severe tolerance and also dependence, which is the most important. So they did some studies on patients and they suddenly stopped the drug and the patients did not develop withdrawal symptoms. Targinact at the beginning was a very effective drug, widely used. Now it's not used, unfortunately, because it's proven after a while to still cause the same problem to patients, which is constipation. So target active is oxycodone, mix it with naloxone. Naloxone is an antagonist of the opioid receptors, and it was designed to help and stop constipation, which is one of the most common side effects. It was effective initially. It was used in the UK. Now we stopped using it completely. It's called Targanet. Rule of thumb: don't use opioids at all if possible. Limit their dose. Even if you decide to use them, always encourage opioid-free periods. So ask the patient to use it from Monday to Friday, for example, and then stop Saturday and Sunday. If you do this, the patient will not develop the tolerance and the dependence as quick. You have to keep monitoring the patient. You have to do urine analysis to check if the patient is misusing the drug, abusing the drug. And then if it's not helped after a period of time, you have to stop it. The fourth line of treatment, these are the least or the last, the end of the queue that you need to use the drugs. Cannabis, cannabinoids, very popular now. People are speaking about it in the news. Many people buy over the counter. It's licensed in Australia and Canada now, not in the UK yet for neuropathic pain, but plenty of studies happening. There is two drugs in the UK. One is called Nabilone. Nabilone is a very famous drug that's been used in the UK for a long time. CIN means chemotherapy-induced neuropathy. People who've got cancer and have and receive chemotherapy, they develop neuropathy very quickly. And Nabilone is licensed to be used with this. Sativix is a spray, and it's a very potent cannabis, and it's now licensed just from November 2019 to use only for patients with multiple sclerosis when they have spasticity. At the Royal Orthopaedic Hospital, we agreed in October 2020, where I work, that we will start a wide RCT to try a randomized controlled trial for musculoskeletal back pain to try to test different types of cannabis and different doses compared to placebo. Methadone, when you read methadone, you would think that this drug is only used to withdraw people of heroin and help in the rehabilitation. Methadone is one of the strongest painkillers. It can be used for severe, debilitating neuropathic pain, but under very close supervision. It's an NMDA antagonist. Do you remember when we mentioned the NMDA receptor and antagonist last time? Like ketamine. Ketamine works the same as methadone. It's a very effective drug. You need to be very cautious with it. It has got very good oral bioavailability, so absorption is brilliant from the oral medication. However, the elimination do you remember when I told you we start low and then increase and go up slow? For the methadone, we start high, give the patient a good effective dose, and then start reducing the dose after that, because you don't want the drug to accumulate and become toxic. This is the elimination is zero order kinetic as well, as we mentioned. Not much evidence. Quick slide about SSRIs, selective serotonin reuptake inhibitors. These are pure antidepressants, such as citalopram, escitalopram, fluoxetine. Citalopram in a small study has proven effective in some cases of neuropathic pain, but it's not widely used, not widely tested. Fluoxetine is a very, very common antidepressant in the UK. It's not effective to help with pain. It helps only with depression. Combined NNT was 6.7. We're happy with an NNT of 5 or less. Some people would say 10 in some drugs, but no. We need to be very careful of something called serotonin syndrome. If the patient takes more than one medicine that have a serotonin reuptake inhibitor, then more serotonin would be available at the receptor site. And that can cause a serotonin syndrome, which can be fatal. It can kill. So you need to be, it's theoretic. I've seen one patient in my life with serotonin syndrome that was saved in the hospital with some fluids. So some people overrate it a little bit, but you always need to keep an eye. We don't know a specific dose of each drug, but combining drugs like tramadol, fluoxetine, opioids, and especially I found it that happened early stages with triptans, is used for migraine because they are very strong serotonin reuptake inhibitors. This is the brief. This is the last slide of the presentation before we go to some case studies. You have to start always with simple analgesics with every patient with pain, such as non-steroidals, paracetamol, weak opioids. Weak opioids, when I say weak opioids, I mean codeine. This is probably one of the drugs available in the UK, not much in the Middle East. And then we go to tricyclic antidepressants as the next step straight away. We can combine anticonvulsants with it if it's not enough or if it didn't work or if the patient develops side effect. If you try one drug, then it doesn't work, you can try another. If you try gabapentin, didn't help, you can try pregabalin. SNRIs are very helpful, such as duloxetines, specifically for something like peripheral diabetic neuropathy, and we're testing it for neuropathic knee pain with some good results. Carbamazepine is only for trigeminal neuralgia, and opioids are not advised unless you've tried everything else and you have a plan and a contract with a patient to be used for short term. I'm nearly finished. We're just going to discuss interesting cases now. I've got 6 cases, and these are real cases from the clinic. The first one is a 47-year-old male with burning pain and pins and needles. So he presented to clinic with severe pain, it's burning, pins and needles in both feet at night. I know what you're all thinking now. No trauma, no injuries, no previous surgery. When you ask about his history of comorbidities, which is very important, as we said, he's type 1 diabetic. He's morbidly obese. His BMI is 44. His hemoglobin A1C, the last one, was 15%. He's a heavy smoker at the same time. He's got ischemic heart disease. He tried different types of tricyclic antidepressants and pregabalin with very limited benefit. The question is, what investigations can we do for this patient? What do you think the differential diagnosis, and what is the management plan? If you think of this patient in a whole, I would give you like a differential diagnosis. Patient has got pain in his legs. Many things can cause leg pain. It's a burning pain in the legs. But think of it, it happens at night mainly, so it's nocturnal pain. It doesn't affect him when he's walking, because you can always think of one of the commonest causes of bilateral leg pain around the feet and the calf is neurogenic claudications. If the patient has spinal stenosis, spondylolisthesis, or any degree of spinal stenosis, this causes a pain called, we call it stenotic pain, or we call it neurogenic claudication. But this pain happens when the patient starts walking, where he feels severe cramp in his leg. And interestingly, most patients with neurogenic claudication will tell you, doctor, when I lean forward, so if he's still going for shopping and he's pushing a trolley and he starts feeling the pain, if he leans forward on the trolley, the pain goes away because he opens up the spaces in the spine. This patient didn't have any back symptoms at all. He didn't have any pain in his back. He didn't have pain walking. His pain was morely at night and burning pain. Then what else can we think of? Could it be a vascular ischemic pain? That's very important, and it's very common, especially if you read the patient is a heavy smoker. The patient has got ischemic heart disease. So we need to ask this patient to go and have a lipid profile. He needs to have full investigation, including a lipid profile. Electrolyte disturbance can cause pain in the legs as well, but not typically burning pain at night time. Vascular, you need to test the pulsation on examination. You need to look for any autonomic changes, like color changes, like cold extremities. With dorsalis pedis pulse, you need to feel it. You need to feel the popliteal pulse, the femoral pulse. You will find these effective. If you're thinking of something, you need to send this patient for a Doppler. Look at that. This patient was diagnosed as a peripheral diabetic neuropathy. We very rarely see these patients in the pain clinic. Why? Because they are treated under the diabetic clinic, usually by the diabetic doctors and nurses. The medicine that worked very well for this patient is duloxetine. We started on 20 milligrams and increased it to twice a day, and then we went up to 30 twice a day. Okay, before speaking about any medicine for this patient, what is the most important treatment that if you don't do whatever you will give the patient, he will never get better? Controlling his blood sugar. Because do you remember what we said? We need to find a cause and treat the cause first. This patient, his diabetes is not controlled. His HbA1c is 15, that's very high. If he doesn't control his blood sugar, his pain is not going to get better. This is a complication of his diabetes. So that's more important than giving him any medicine, is to look for the cause and treat the cause first. So this is the first case. Can we send this guy for nerve conduction studies? I would say no, because nerve conduction studies are very non-specific for peripheral diabetic neuropathy. It's a small fiber disease. Many patients come back as normal. Case 2. This patient is a female. She's 19 years of age, very young to have chronic pain. Where is her pain? The pain was more in between the thoracic and the lumbar region when she came to clinic. Once she entered the room and you find that one shoulder is lower than another, you know, especially I work in a hospital that is a tertiary referral. It's one of the biggest centers in Europe to treat, to do operations for correction of deformities like kyphosis and scoliosis, especially for young people. So I knew from entering, because I see many patients like her, severe thoracolumbar back pain. Very difficult, and so she had surgery, extensive surgery, a big scar from high up from thoracic down to the lower lumbar in her back at the age of 15. Then examining her, we found a very painful scar, hypersensitive scar in the back. And then after this, she came with her mom. Her mom in clinic was very, very quiet, not speaking much. She was quiet. She didn't have any eye-to-eye contact. As we said last time, you need to assess the patient as a whole. It's not only the pain. It's a biopsychosocial problem, chronic pain. So the patient has no eye contact. She's always looking at the ceiling, looking at the ground. She looks depressed. She's got an anxiety. How can we treat this patient? What can we do for her? Can we actually find a cure for her? She's got very sensitive scar, severe allodynia and hyperalgesia along the whole scar. Okay. This patient was assessed in our multidisciplinary clinic by myself, a physiotherapist, and a psychologist. The physiotherapist find severe muscle spasm in her back due to fear avoidance behavior. Fear avoidance behavior means when the patient starts feeling pain in the back, they think that we have something bad in my back. If I move more, I will damage my back more, I will get worse pain. So this is all his thinking, his knowledge. He doesn't have the knowledge. He doesn't know what's happening in his back. So he stops moving. And when he stops moving and lies in bed most of the day, he gets a muscle spasm and the pain gets worse. So the physio started educating her, teaching her some stretching exercises, but she can't do them because she's in severe pain. So what can we do about it? I'm going to answer this question now. But also the psychologist fully assessed this patient in clinic. Do you know what she found out? You can't believe what she found out. She found out that this patient was sexually abused by his stepdad from the age of 8 up till the age of 17, with the knowledge of her mom. This patient suffers severe PTSD, post-traumatic stress disorder. She diagnosed her with this. And she said that we will start urgent psychotherapy for her to help with her post-traumatic stress disorder. So can you imagine now how many problems this patient had? And how did we know that? Because she starts telling things that lead us to this. I'm homeschooling. She doesn't go to school. Why don't you go to school? Most people go to school. Her mom doesn't send her to school. She's always at home. She doesn't have friends. She's hoping to go to university. She loves law and she wants to study law, but no one is giving her the chance to do this. So we reported this to the social services department at the hospital. We have a department called safeguarding. Adult safeguarding and child safeguarding. If I feel that there is a danger for a child or an adult from one of his family, I have to report it straight away and they take actions. It's very important. So PTSD will be treated, okay? Then I'll tell you what happened with this young patient. And then the physio said, I can't do any exercises. So I took the patient to theaters, used an x-ray, and I did an injection that every pain doctor would do, facet joint and medial branch. But I told the patient, I'm not doing this to cure your pain. I'm doing this to relax your muscle, give you some pain relief so you can do your exercises and be more flexible and strengthen your back muscles. And then the psychologist treated her PTSD. And then after the PTSD, she joined our pain management program. This is something that maybe we can discuss in a separate lecture. It's an 8 weeks program that teaches the patient how to live with the pain. They give them the knowledge about why are you feeling pain. They teach the pain pathways in a very non-medical way, easy way. And they set goals. That's very important, of something that I should have spoken at the beginning about with every chronic pain patient in the clinic. What is your goal in life? I will not treat your pain. What do you want to achieve that I can help you achieve? So they set goals with the patient. This patient, after 1 year of treatment, went to university. Her pain is not gone. Unfortunately, I said we can't cure her. I told her from the beginning, but she is 50 or 60% better. Yeah, she started walking because she enjoyed long walks, and her mood has improved. The social services work too. So there are many aspects, social aspects, psychological aspect, and physical aspect. So you have to target all of this. And this is case number 2. Can I tell you something about this patient? This patient didn't have a single medicine. She didn't take painkillers. This patient improved without medication. Case 3 is a 92 years old female. This age we see a lot in the UK. They live to older age here. They're in good health. She presented to me in clinic with severe pain on one side of the body, lower thoracic on one side, suddenly started, severe burning. She can't even touch the skin. You can always guess what the diagnosis is just from this picture. This patient, but I know it's an easy case. This patient was diagnosed with peripheral post-herpetic neuralgia, shingles. But the reason I'm mentioning this case is how we dealt with it, because this patient came to my clinic because the condition sometimes starts very, very, very severe. She was suicidal. She said, "I want to end my life, doctor. I will kill myself. He needs something to help me." Tearful, no sleep at all for a week. You can see from her eyes. So in this case, we need to start by aggressive treatment. In normal circumstances, when I see a patient like this, I can give him some neuropathic pain medication and send him home. I can't do this for this lady. Yeah, we kept her at the hospital for a day, just one day, and we started her on the Qutenza patch. Do you remember the Qutenza that I mentioned in the last slide? And I said, remember this: 8% capsaicin, very, very high concentration of capsaicin. We place this on the patient's chest for 3 hours after putting ice packs, because it can be very painful and burning on the skin. Okay, and at the same time, we started her on pregabalin. She's 92, remember, and I told you pregabalin NNH is 11. Side effects profile is high. You don't want a 92 years old to take a drug sedating and fall down and break her femur or break her pelvis. You need to be very careful. We started her on 25 only, very small dose. 25 pregabalin plus the the Qutenza patch. If in your country you don't have the Qutenza patch, give them capsaicin cream and ask them to rub it 6 times a day on the painful area. And then we tried the capsaicin, and then we sent her home the second day. And the first, after she was 50% better, leaving the hospital 50% better and happy, she said, "I'm improving, doctor. I'm not thinking of killing myself anymore. There is hope in life. There is hope." So we gave her some hope. We didn't cure her still. After 4 weeks, she called the office and said, "My pain is back again, doctor. What can I do?" Okay, we gave her some lidocaine cream, 5%, and then we used the lidocaine patch. We asked the GP to give it to her, which helped her pain for 50%. And then we bring her now to the hospital every 4 months and give her this Qutenza treatment, okay? But shingles, post-herpetic neuralgia, start severe usually, and most of the patients I see, they improve. I'm sure I'm going to get some questions and tell me, okay, why didn't you do a dorsal root ganglia block? Why didn't you do a dorsal root ganglion pulsed radiofrequency? Believe me, I've done plenty of these. And one of our very knowledgeable lecturers, I hope he's listening to me now, Dr. Muhammad Makharita, he's published a lot on post-herpetic neuralgia. He's very experienced in this field. And he would tell you, I mean, we put all types of injection, dorsal root ganglia injection, nerve blocks, all these things help for a short period of time. They will not cure the problem. It's self-limiting. Shingles and post-herpetic, most people get relief by time. They get helped by time. So why do you expose them to an injection with risks? Try conservative treatment and medicine first. Then if this patient would not improve, I would have considered doing an injection, but always start with conservative treatment. Case 4, 50, sorry, I've got 3 more cases, but they're all very important, so we have to mention them. 5 minutes and we'll finish. 56 years old male police officer. I remember this guy as if he's yesterday. He's a very nice person. He's a police officer that presented to me in clinic multiple painful problems. He's got many problems. You know, he's coming using a stick, and he said, "I use a wheelchair when I go outside." He has severe burning pain in his knees, and there is a big scar in his knees. He was wearing a short when he came because he's got hypersensitivity in the knees. He had total knee replacement, and it didn't work well for him. Apart from this, he also had back surgery. So sometimes we get these patients in pain clinic, many problems at the same time. What can we do about these? He had decompression surgery to his right leg. So, to L4-5 decompression. In Egypt, I think they do laminectomy. They stopped doing this in the UK, and they only decompress. So they remove the part of the disc that is pressing on the nerves. Usually they do it microscopically, microdiscectomy. I'm sure they do it also in Egypt and the Middle East. Many patients after these operations, although it's a very minimally invasive procedure, they end up with chronic pain. Because of what? Because of what's written here. Post-operative fibrosis. Scar tissues build and press on the nerve again. So you release the disc off, but scar tissues build in and press on the nerve again. So he's had the same radicular pain, the same sciatica pain that he used to have before the surgery. He said, doctor, the surgery was very good, but only for 6 months, and the pain is back again. He tried pregabalin, he tried all types of tricyclic antidepressants, and he tried duloxetine. No help. Yeah, he had a nerve root block. He had an epidural. No help. He had a spinal cord stimulator. This is the end stage that we do for these patients. Spinal cord stimulator. I'm sure you heard of it. It's a device that is inserted into the spinothalamic tract, stimulates the spinal cord, and gives good relief. He had it. He said it was very good, doctor, but had an infection, which is common with it, and they had to remove it. And then the most important, you have to ask about this. When you see a patient like this, do you think you can cure him? He's been having this problem for 15 years, something like this. Can you cure him? If you tell the patient, I will cure you, you're lying to the patient. You're definitely lying to the patient. Whatever you will do to the patient, it will be just to help him. So the first thing I ask the patient, he said, doctor, I know there's nothing you can do for me, but please, anything to help. He's divorced. His wife left him because of his pain, because he can't do anything. It's very common in the UK. Lost his job. He has no income, and he's applying for benefits from the government. But when you see people like this, you like to help them, because he used to be a police officer. He wants to work again. He's very depressed. So we put on goals. He said, doctor, and I said, what's your goals in life? 1, 2, 3, 4. He said, I want to be able to do my gardening again. I have a garden and I like to do the gardening. I wish I can do it again. I wish I can walk to the shops and buy myself my groceries again. That's goal number 2. Number 3, I want to sleep well at night, doctor. I don't sleep. Okay, that's all he wanted. He said, I want these 3 things, doctor. If you're able to do these things for me, I would be very happy. So we started targeting one by one problem in him. What's worse? What stops you walking? Is it more your knee scar, or is it more your back and radicular leg pain? It was actually the knee. So we started working on the knee. We sent him to physio. They start doing something called desensitization, because he had symptoms of CRPS in his knee. Yeah, we gave him creams, topical creams, duloxetine, lidocaine. We started him on extensive doses we started him on something called an opioid contract. We agreed that we will start you on morphine tablets, but only for the next 6 months, to put you back on your feet, and then we will reduce him again. Only for a short period of time. And because he's a sensible person. I would not start morphine of someone who has a history of drug addict, of someone who's got social or psychological problems. But people like this, professional, who had problems, I'm sure when they start morphine, they will be sensible, and they will stop it at some stage. They will not take it, they will not abuse it. Yeah. This patient was treated very successfully, and I was glad to say that also his fibrosis, which doesn't work for everyone, I did a Rax catheter procedure. I'm sure you all know about this as well. It's Rax is Gabor Rax. He's an American consultant that invented a catheter that breaks down some adhesions mechanically, and by also injected some hyalase, which is an enzyme that breaks scar tissues, and also hypertonic saline. So I did this procedure for him, and it managed to improve his leg pain a lot, but only for 6 months, and he have to come back and do it again. But we managed to achieve his 3 goals. He went back to his gardening, he can walk again, and he can sleep better with the help of the medicine. Yeah, that's case 4. Case 5, 34 years old, single mom. She has 5 children. She presented with back and leg pain, non-specific. So everywhere she said, doctor, my back is hurting me all, but more in the buttocks. Her joints ache, tenderness all over. She's fatigued. She sleeps very badly at night. She's got headache every day, and she got constipation and diarrhea all the time, alternating, and anxiety, depression, differential diagnosis. I'm sure what you all think of. Yeah, fibromyalgia. Yeah, very common. We see it. Young, middle-aged women, more likely. We don't know an exact cause, but this patient, I will tell you interestingly about this patient. It wasn't only fibromyalgia that is causing the problem. When she came to clinic, she brought me all the bloods that she had with the GP, all inflammatory markers, CRP, rheumatoid factor, anti-ANA, all these things negative. So no inflammatory problem, no autoimmune problem. So it's fibromyalgia. And then we would treat her like fibromyalgia, physical therapy, neuropathic pain medication, increase the level of activities. She also joined our pain management program to give her knowledge about her pain. We do also treat patients in pain management program by something called APT, which is a very new psychological intervention, acceptance and commitment therapy, something similar to CBT, but can be very helpful, and mindfulness. She didn't improve. Worse, 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 and she ended up coming to me in a wheelchair. Fibromyalgia doesn't get that worse, especially if the patient engages in treatment. So what's wrong? Can she have something else? So you know what she found in this lady? I thought, well, why not do the bloods again? So I spoke to a friend on the phone, a rheumatology consultant. And I said, what do you think of this lady? I'm just worried that she might have some hidden autoimmune disease or inflammatory arthritis. He said, send her for more bloods, all the bloods that she did again, and also send her for a MRI gadolinium and a bone scan. So we did all these investigations for him, and we found that she has severe sacroiliitis and ankylosing spondylitis. So she has inflammatory arthritis, this lady. So what did she have? She started by some infliximab. I'm sure you know about the new TNF inhibitors or tumor necrosis factor inhibitor medicines, such as infliximab and Enbrel and many drugs now. Infliximab helped her by 20-30%. They changed it to another drug called Humira or Enbrel, which is another, and that gave her 90% relief of the pain. Can you imagine that? These drugs are quite expensive. But this lady, from being in fibromyalgia, telling her that you're not going to be helped at all, now we found another thing. So you need to look for everything in the patient. You need to follow up the patient. New symptoms can come. Is the patient getting better with your treatment? Is she getting worse? Follow up is very important. Last case. And relative. Had severe burning medial forearm and hand. So apparently she had the ulnar nerve injury specifically. Burning, swollen hand, mottled, got dots of red, cold, weak grip, severe hypersensitivity. These are all the criteria of CRPS, chronic regional pain syndrome. I would urge everyone to look at the CRPS criteria. There are, if you Google Budapest criteria for CRPS, these are the ones that we use in the UK, and they're very effective. She tried everything. Pregabalin, amitriptyline, non-steroidal, nothing worked. But this lady, unfortunately, had her physio very late. Physiotherapy and what we call desensitization should be the first line of treatment for CRPS. If you delay it for 3 or 4 months, the patient will not get better. Interestingly, she found the amitriptyline very sedated. When you changed her to nortriptyline is less than amitriptyline with less side effects. Her sleep at night improved, and then we started her on an extensive course of physiotherapy, and she improved by something like 30 to 40% only. That's my last case, and sorry for the long lecture, but we had to go through all of it. Thank you very much.
Thank you very much, Dr. Kafafy, for this magnificent lecture and these magnificent actually cases as well. It's very interesting. We have loads of questions for both of Professor Mana and Dr. Kafafy. Excuse me, Dr. Kafafy, I'd like to start with Dr. Mana.
Of course. Yeah,
because, I know it's late now in Saudi Arabia. And so a lot of questions is asked about the postoperative nausea and vomiting in awake craniotomy. I know that you mentioned loads of medication that used as an antiemetic, but like, what's the best combination of antiemetics you prefer to use? And one of the attendees asked about using of metoclopramide, known about his side effect for the neurosurgery.
Yeah. Of course, metoclopramide, it has side effects like extrapyramidal manifestation, but in high doses. But while we are using intraoperative propofol infusion itself is antiemetic. And we may use propofol small dose infusion for the patients even away from awake craniotomy. In any surgery, you may use propofol infusion with a small dose as anti-emetic, but the best combination you should combine with the prevention and management rescue treatment. For prevention, one of the best is dexamethasone, and the one of the prevention of the post-operative nausea and vomiting rescue treatment, I mean, is ondansetron, of course, no doubt of this. But the combination of propofol with giving pre-operatively or intraoperatively dexamethasone and ondansetron to be ready for treatment of the rescue, this is the best management for post-operative nausea and vomiting. And one other factor is to avoid dehydration, because dehydration is stimulating the post-operative nausea and vomiting. You give the patient the requirement amount of fluid supply and to give generous amount of analgesia, because of the traction on the dura and the blood